Welcome to the PinkpillRx podcast, hosted by Katie and Jay Fillmore, where we navigate complex and thought-provoking topics surrounding women with a focus on education. For shorter form content, follow us on TikTok, Instagram, or YouTube at Caters88 or PinkpillRx.
That's KATORS88.
If you enjoy this podcast, please give us a follow and maybe a nice review.
Welcome back to another episode. A couple announcements before we get started here. For the rest of December, we are actually not going to be releasing any new content. And then starting in January, we are changing the schedule on which this is being released. Right now, it's every Monday, but we're going to change it to every other Monday. Sorry to disappoint anybody, but we're getting a little burnt out and we want to keep doing this. And that's the pace in which we feel like is sustainable.
Yeah, we both work and we have children, and just this is, it's a lot that we juggle a lot. Yeah,
this is our hobby.
Yeah, that's how much we love it. We just do this as a hobby.
It's really cool. It's been an honor. Really, it has been an honor. This has been quite the journey with this podcast, and it is my favorite thing that we do as far as content goes.
Yeah, it's always amazing to hear the feedback and the. How it's impacted people,
Yeah, it's been really powerful for us. So today's topic was brought to my attention by a listener who messaged me and said, can you talk about the different lab value ranges that are based on the male standard? So we're going to talk a little bit about medical sexism today. We have touched on medical sexism throughout, this whole journey, right?
So much insanity.
Of it. But
I still can't believe, anyway, go ahead.
No, what? You can
No, it's
continue.
just still shocking. I mean, the medical stuff is shocking that, female test subjects in human trials for drugs, not really existent until the 90s?
Yeah, it was required in 1993 for NIH
Right,
funding,
for NIH funded, so it's not even everything.
We're going to get get more into that.
There is one thing I heard that was good news.
Tell me about
recently, that when they do auto crash simulations with dummies, they are now going to they are now going to require them to also use female crash dummies.
That's 2025 for you, baby.
I mean,
that's progress.
Yeah, and I'm sure there's a lot of lamenting, like, well, it shouldn't have taken a 2025.
Oh,
totally
for
agree.
sure,
absolutely. But I think it's great to see, like you said, progress.
Yeah, there's progress there. So, but did you know that the way women's health markers were historically determined is a textbook example of systemic bias in medicine?
I don't really know what that stuff. What lab markers? I don't really know what. Explain it to me like I'm 7.
Like labs, like you go get your blood drawn and they say, this is the normal range for this.
Okay. Shoot. All right. So you're for real. Okay. Someone's going to comment, my man just had a whole range of emotions in 10 seconds. So all the norms are based off of male participants in studies and stuff?
Well, it has gotten better. But most normal ranges and clinical guidelines were originally based almost entirely on male populations.
Oh, God.
So up through the mid-20th century, women, especially those of childbearing age, were routinely excluded from clinical trials and the development of these ranges.
And so, like, give me, okay, I know we're going to get into it, but examples of ranges would be like if you have a metabolic lab done.
Yeah, like
or a CBC
normal hemoglobin. So a normal blood count.
Yeah. Oh, my God.
Is this. And for the longest time, they didn't take into consideration women having a different normal count. And you got to think about that, too, because what do women do every month?
Oh, bleed. Yeah, I mean, your iron's got to be all over the place. And like you said, hemoglobin and...
Yeah, so we're going to, like I said, things have gotten a little better. So there are some ranges now that say, okay, if you're a woman, this is your normal. If you're a man, this is your normal. But we're going to go through.
Okay, if you get a CBC, then does it matter where in your cycle you are? Because if you're bleeding I mean,
Oh, it could have an impact.
like
yeah.
in what phase or whatever?
Well,
you're
see,
in?
and that's why they excluded us.
Oh, it's just too complicated.
Yeah, the hormonal variability was seen as a complicating factor.
Yeah, man. So I guess, I mean, all the science is pretty complicated, running labs and looking at, I don't know, things that are on a smaller than a cellular level, but it's just, it's the straw that broke the camel's back.
Yeah.
Adding in the cycles, I don't know.
It's too much.
That's nuts.
Yeah, lab reference ranges, and this even like extends to like what's normal blood pressure. So normal blood pressure, normal cholesterol levels, kidney function, even heart rate were derived from male data.
So you can have markers that say something's wrong, but it looks normal because it's normal for a guy, for a male.
Yes.
And then the woman goes and has a heart attack. I mean, I don't know if that's true. That's obviously an extreme case, but that's kind of what we're talking about.
Yeah, that's kind of what we're talking about.
Okay.
Yeah.
Whew.
So hemoglobin, hematocrit, and creatinine reference ranges were based on men, meaning women with abnormal values could be misclassified as normal
Right.
when they weren't normal. Because of these skewed lab ranges, women were often misdiagnosed or underdiagnosed with heart disease, autoimmune disorders, and osteoporosis specifically, were often went unrecognized until very advanced stages. Same thing with liver disease. Women's like labs would come back, quote unquote, within normal range. And so then their symptoms were attributed to like stress, anxiety, or psychosomatic causes. This is like a side note. On top of the hormonal issues, one of the reasons that women were excluded from studies was because there was this bias that women were more emotional and less capable of giving reliable symptom reports.
Dude.
Isn't that crazy?
Yeah. So but then if you were African American, your pain is exaggerated, right?
Yeah.
That's
right.
a thing too.
That is a thing.
So then like what? It's just white males that are actually listened to about their symptoms? Or listened to the most
Yeah.
anyway.
Yeah. And you bring in an interesting variable as well, because there are, for like African Americans or for people of different races, their lab normal ranges for certain things could be different.
I mean, that makes sense too.
Yeah. And there's not really a lot of
That's awful.
research or like reliable, consistent referencing for that.
I would think that those in medicine would be more objective and less biased and more like science driven. This makes the most sense. We're going to research all of these subgroupings too.
Yeah.
Unless there's politics. Well, it's because there's money involved probably.
Yeah. So, like I said, a lot of these lab references were based on men. They excluded various races, age, and body composition, which matters because, if you have more fat, for example, as a woman, you tend to have more body fat. That does affect your labs and stuff. So it was standardized on a narrow population, a white male, 20 to 40 years old. That's where we get our normal lab values from.
Okay.
I want to say this, though. There are labs now that it will actually say, like, if you're a woman, here's your reference range. So here are some labs that have had that impact on women. Creatinine and GFR. It was originally derived from young, healthy men. It assumes a higher muscle mass because men have a higher muscle mass. Mm-hmm. So the effect on women is that kidney disease went underestimated, and there is a delayed diagnosis for chronic kidney disease. And do you remember the transplant episode we did where we talked about women getting on the transplant list later? Mm-hmm. Part of that has to do with this. Troponin, which is a cardiac marker, it was all tested on male cardiac cohorts. The men had a higher male baseline for that to be in normal. Mm-hmm. Women were getting they were missing heart attack diagnoses.
Because their levels were higher, but they look normal.
Yes.
Yeah. Oh.
BNP, which helps like diagnose heart failure, for example. It was tested on men, or that normal was based on men. Body fat and hormone differences were ignored, which can affect BNP. So women would get a false normal result, and they would get underdiagnosed for heart failure.
That is so scary.
ALT and AST, which are like liver enzymes.
Yeah.
Male weighted samples were used. Mild liver disease in women appeared to be normal. And so women were missed. Like liver disease was missed in women. Also autoimmune diseases.
And then they chalk it up to psychosomatic stuff.
Yeah.
Man, it's so gaslighty. It is nuts.
So hemoglobin and H&H, hemoglobin and hematocrit. The hospital I worked for, their lab, they did have a normal reference range for men versus women. So that's
nice.
That was nice, yes. But basically, based on male blood donors is what they did. And low hemoglobin was essentially normalized in women. And what happened was the clinical consequences of that is women would come in with like chronic fatigue and like a deficiency because their hemoglobin was actually low. And it was overlooked.
Right, because it was within the male normal
Yes.
range, but that really wouldn't be in the female normal range.
Yes. Ferritin, same thing. Female depletion ignored. Iron appears adequate, but they missed deficiencies. Thyroid hormones, TSH, T4, they excluded hormones from it. So they did it on men and they didn't take into consideration. They like ignore the female cycle. So normal TSH may hide subclinical hypothyroidism. So undiagnosed thyroid dysfunction is what that results in.
Isn't what's produced in the thyroid technically a hormone?
Yeah.
And they wanted to exclude
The female hormones.
female hormones, but this is a hormone lab?
Yeah. Cortisol, another hormone.
Right. Stress hormone.
Men. So stress and adrenal fatigue was misread for women, and there was a misdiagnosis of like fatigue and adrenal syndromes, like an underdiagnosis of them, and just chalked up to like psychosomatic stuff.
Good God.
Fasting glucose and insulin resistance. Hormonal phases ignored again. Women appear normal. This results in delayed PCOS diagnoses and insulin resistance detection in women. Lipid panels, female HDL patterns are dismissed, and atypical lipids are missed, and so cardiovascular risk goes underestimated in women.
Because that's cholesterol, right?
Yeah. Mm-hmm.
Okay.
Vitamin D and B12, again, hormonal and fat differences are ignored in women. Low levels appear normal, and this causes bone, neuro, fatigue issues that are missed. CRP, ESR was all done on healthy men, which has caused chronic inflammatory and autoimmune activity to be dismissed in women. So those are a couple. We're not even talking about drugs at this point. We're just talking about labs.
Right.
The bottom line is the muscle mass, hormones, metabolism, and immune activity still carry male calibrated biases, which normalizes pathology in women and causes issues to be ignored. So this got me thinking about like, okay, well, what about like imaging? Does this like, what about imaging?
Like X-rays,
X-rays, MRIs, ultrasounds,
scans.
CT scans, etc. Because I'm like that, obviously composition of the body is a little bit different. Like, is there?
Yeah, we have whole organs that we don't have.
Right.
I mean,
True. Well, what I found was that there wasn't anything like similar to the lab ranges that we were talking about, but that there is evidence that radiology reports can be misinterpreted because they're influenced by prior notes from the doctor, including doubt casting language. So if in the notes, they read the notes first for the test, and in the notes, the doctor mentions that the patient is anxious or something like that, it is more likely that the radiologist finds the imaging as normal.
Really?
Yes, or like due to like psychosomatic stuff and not like pathology.
Are there studies done on that?
Yes.
That is insane.
And whose charts are most likely to contain that language?
Oh, female.
Females
Patients.
and also people of color.
Yeah. Yeah.
are going to have doubt casting language. It's labeling a patient as something. So findings interpreted through stereotypes or expectations from patient demographics or descriptions they found would impact the reading. So the kind of rule of thumb is don't read the notes until you read the report. Like don't read the notes until you read the imaging.
So you won't be influenced.
So you will not be influenced by any doubt casting language.
Yeah, that just makes sense. Yeah.
But isn't that crazy?
Yeah.
And then I want to talk about medications a little bit here, which we have touched on briefly. You know, you were right. 1993, the NIH starts requiring women to be included in federally funded research. Here's the thing. In 2023, there was an analysis done of, we're talking about drugs here, of approved drugs, that these drugs were studied between 2010 and 2019. And they found that the NIH funding covered less than 26% of phase 1 and 2 trials and under 5% of phase 3 trials. So if it is not done by the NIH, funded by the NIH, they are not required to have female representation. So when you look at these numbers and see that like phase 1 and 2 trials, about 26% were funded by NIH and under 5% of phase 3 trials, there's not a ton of trials out there that are being funded by NIH overall.
Right. So they have no obligation.
They have no obligations. It's usually like private funding or funding within universities or things like that.
Yeah. So really what would need to happen is you would need to have federal like regulation legislation.
For all research, yes.
Right. Otherwise you can only control what you fund.
Yes. And I will say that the NIH, they found that their 1993 ruling of like, hey, you need to include women wasn't really like being followed the way that they wanted it to be followed. So in 2016, they came up with another policy. It's the SABV policy, and it requires sex consideration in design, analysis, and reporting. So they had to like redefine it, basically, or like add on to it
because they
were still getting underrepresented.
Yeah, they found a way around it.
Yeah.
Gosh, why would you try and get away around it?
Like, why does it matter so much? Well, women metabolize drugs differently, and that underrepresentation in these trials increases adverse reaction risks.
Because your dose is probably too high or too low?
Exactly. Women have different liver enzyme activity. Liver enzyme activity is higher in men, which causes metabolism to be different because a lot of drugs go through the liver to be metabolized. Women have higher body fat and lower water content, which can affect drug absorption. The renal clearance in women is slower, and the GI absorption and transit differ between men and women. So how does this shake out? Well, roughly 50 to 70% of serious adverse drug reactions occur in women. So a drug reaction in which you need to be hospitalized, 50 to 70% of those are women. Women are 1.7 times more likely to experience side effects from medications than men are in general. So that's not like a serious side effect. It just is side effects, period.
Yeah. Oh, yeah, because their dosage is off.
Their dosage is off, right? Here are some drugs that are affected by that.
Whoa.
Ambien, women metabolize much slower. There was like lawsuits on this because women were like getting up in the morning, being super sedated and driving cars and having accidents.
Oh, dang. Oh, because it's still in their system.
Yeah, the FDA recommends now half the dose.
Half
the dose.
That's dramatically different.
Yes.
Like, that's quite the miscalculation.
Yes. Similar with Lunesta, slower clearance in women, increased next day drowsiness compared to men. Benzos, slower metabolism in women. They have greater sedation and it's a longer half-life in their body, so it stays in their body longer. Morphine, women experience stronger analgesic effects, so standard doses may increase sedation, nausea, and respiratory depression.
Well, that's dangerous.
Kind of a big deal.
Yeah.
Fentanyl, women tend to have higher plasma levels and have stronger effects from it. Oxy and hydrocodone, women are more sensitive. Ibuprofen, slower clearance of the GI, there's greater renal risk in women.
Oh.
There's an increased risk of kidney or GI injury for taking NSAIDs in general for women.
What are NSAIDs?
Like ibuprofen, naproxen, things like that.
Acetaminophen?
No, acetaminophen's different.
Oh, okay.
Digoxin, women have higher sensitivity. There's an increased mortality risk at standard doses. Like women could die.
Oh, gosh. Oh, my God.
Warfarin, which is a blood thinner, women metabolize differently. They have an increased risk in bleeding and may need lower doses. Same thing
So you're
with...
not going to clot.
Yeah. Same thing with heparin. Women have an increased bleeding risk if it's based on a male, like the male centric dosing, women are at high risk for bleeding out.
That is, some of these are terrifying.
Yeah. Beta blockers, women have a stronger blood pressure and heart rate reduction with them. So their risk of bradycardia or hypotension, so low blood pressure or low heart rate, is a lot higher. ACE inhibitors used for blood pressure, women respond differently. There's a risk of hypotension again, and they may need like really careful titration with it. SSRIs, women actually respond better to them than men. And so standard male dosing is actually overdosing women and causing an increased side effects in women. Same thing with antipsychotics. There's an increased risk of sedation and metabolic side effects for women. Lithium, there's a risk of toxicity at the standard dose.
Can I ask a question? Or you want me to wait till you're done with going through some of these?
No, you can ask.
So a lot of these drugs have a minimum dose to be therapeutic.
Right.
So could you argue that for women, some of these therapeutic dose thresholds should be lower?
Yeah, and some of these, yes.
Like if the smallest that you can get a prescription for is 20 milligrams. Maybe women need one that their first one should be at 10 milligrams?
Possibly.
Wow.
Levothyroxine, which is very common for thyroid. Hormonal cycles alter TSH response, so standard dosing may miss hypothyroidism or overcorrect it.
Oh.
Diabetes drugs, women respond differently. There's a risk of hypoglycemia, so they respond differently. So their blood sugars could actually drop faster than a man's. Statins, which is for cholesterol, women are more sensitive to myopathy with it. So the same dose like they would give to a man may increase the risk of muscle toxicity in women. Iron supplements, women have a higher need for them. So male-based normal can actually mask deficiency. Like women need probably a higher dose of iron supplementation. Ferritin cutoffs are same. They're historically male standard. And so iron deficiency is underdiagnosed in women and undertreated because the standard dosage for iron is based on men, from my understanding. That's all I have for the medications. There's tons of them. Actually, there was a study that was done where they took 86 widely used drugs, and 76 of the 86 of them showed significant sex-based differences in absorption, distribution, metabolism, or excretion. I mean, that's like almost all of them.
I'm going to calculate that really quick. 76 out of 86. Yeah, it's 88%.
Yeah, so 88% of the drugs that they tested showed significant sex-based differences.
Yeah, and you could even say, oh, so only 12% of drugs would the dosage be safe? For
yeah,
both.
if you were to take this study and like generalize it.
Yeah, I mean, it's a small, I don't know what the sample sizes and stuff look like, but that's really frightening.
So, I mean, when you're going to your doctor and you're going through these labs and you're going through these medications, you know, the good questions to ask is like, is there a dosage that, are you basing my dosage or are you basing these lab ranges based on my biological sex?
Yeah. You know, I recently switched primary care physicians, and I purposely, for several reasons, one of which, though, is I wanted a female primary care physician. I thought I'd be listened to more. So far, it's proven true. And I have follow-up labs that I'm going to be getting like the next week and a half. And I want to ask her at my follow-up visit, if I have one, about it.
Oh, about the lab ranges?
About the lab ranges and stuff.
Yeah, I mean, I do feel like it's like pretty downplayed. Like as in if it doesn't make that much of a difference. And like I said, some labs do have the lab ranges that are specific to women on some of these things. So science, medicine, whatever is catching up to some degree. I wonder, I bet, and this is just like a thought. This isn't like I haven't looked this up or whatever, but I wonder if women visit functional medicine doctors more often and if they see better results with functional medicine because those people, whatever, I know that like the standard is that bell curve, right? But they don't consider that to be normal necessarily. Like there's optimal versus normal.
Right.
And so I know functional medicine is more based on like optimal versus normal.
Just because it's normal doesn't mean that it's optimal. It just means that it's normal for your population group. In this, probably just in our country.
In some of these, the population group is a white male between 20 and 40 years old.
Yeah, you fit in the normal part of the bell curve.
Good job.
For 20 to 40-year-old men.
Yeah.
Did you know?
Yeah. Wild.
Yeah.
Isn't it?
Like if someone to tell me, your labs, they're well within the normal range for a 50 to 80-year-old woman. And I would say, well, that doesn't tell me anything.
Yeah.
What does it mean for me, my age and my demographic?
Right.
I am feeling like when I think of medicine, I think of scientific minds. And this doesn't sound very scientific.
Yeah. I mean, it sounds like you did.
Sounds kind of lazy.
Yeah. I mean, and I think that like at one time, this was probably a great idea because we didn't have any normals.
Yeah, I mean, to get some
so
type
you
of
had to
brain.
get something.
Yeah, but how many decades has it
but
been?
then it's like, when do you stop reinventing it or adding to it is the question.
Yeah. Dude. That's really frightening for a lot of minority groups, including women.
Right.
Even though technically there's more women than men in our country.
Right.
So
yeah,
really,
by a percentage,
So saying minority sounds interesting, but minority from the perspective of...
oh, that's interesting. That is a good point.
From the perspective of power.
Yes. Yes.
Because you're not the minority. You're the majority. But in terms of power, you're the minority.
Right. That's a good distinction.
Yeah, I think 51%, 51 point something percent are women, in our country. So you're not a minority, but you are because of the power structure.
Yeah. Well, I think all this stuff is good stuff just to be aware of and have on your radar, especially if you are, in the medical world, rather you're a provider or rather you are a patient. To know these things is empowering and is going to hopefully help your outcomes.
Yeah. It gives you, additional questions that you might be asking with your PCP or a specialist or something like that when you're having testing done.
Right. Well, thanks for listening. That's what I got.
That was really informative. That was informative and frightening as usual.
Per usual.
I hope for those of you listening, something was intriguing or sparked a curiosity, or you felt affirmed or challenged. Stay educated. Take the pink pill. If you enjoyed this podcast, please give us a follow and maybe a nice review.